Unfortunately, because of my routine, I was not able to conduct a class for some time. Today, I thought even a small bit of it, but I will do it today, definitely. So, mm people who knows me already, I am Dr. Zishan. I am working as a consultant in Prince Sultan Military Medical City, Riyadh. Teaching is my passion, and a lot of people are in my group. So actually, today's agenda is we will be continuing it later on as well. Just a second. Uh, what happened to my status? I'm sorry, just a second. So actually, the thing which we'll be trying to discuss today is like uh, what uh, what what should be our approach when we want to learn about neuroanesthesia. Any one of you volunteer to speak out? Like, what do you think from where we should start neuroanesthesia? Anyone, please. Any volunteer? Anyone want to speak out? If not, okay. Actually, actually, first of all, because that's my first message, try to correlate three things. One is exam, okay. One is practical conduct of anesthesia, okay. People are totally confused in these two things. Sometimes
Yes,
they overstress the
तो
exam.
पेशेंट आया था तो मैं उस
And
टाइम उठ गई फाइल वो रख के गई थी इधर
in this exam, they forget that they have to be a good anesthetist. For that, being good anesthetist, they should know how to have a good practical conduct of anesthesia. So my request to all of the people who are preparing for the exam, and more important, the people who are in the training, just try to have their concept clear. Because if your concept is clear, exam is just like you can say that if you have a clear concept, it's like preparing for a marathon. Okay. No, not everyone can appear in marathon, but if your muscles are tuned for marathon, you can always appear in 100-meter race or 200-meter race, because now you are already tuned for a long journey. Okay. So yes, there will be different technique for achieving high scores in 100-meter race, but the baseline will be marathon. If someone develops stamina to run or jog for a long time, 100-meter race or 200-meter race will be nothing. So this is what is called as like compact learning. Unfortunately, you people over stress on exam. When you are over stressed on the exam, and there are people who give a idea, first of all, clear the exam, knowledge, there is whole life to get knowledge. No. If you have good knowledge, exam will be at the tip of your shoes. You can you can crack any exam if you have good concept. But if you don't have good concept, yes, maybe you pass one exam, but you will be stuck in the next exam. So this is the basic. Then in different part of world, there are different sort of exam pattern. One is MCQ, one is written. Okay, then oral part. In oral part, there are sometimes a patient centered exam or paper scenario, like patient in which original patient is there and you have to take the history and examination, and some is case based. Okay, so you have to be. Oh, and then third part is OSCE, that is objective assessment of clinical skills. Okay, so you have to be. And then, as I told you, that practical conduct, when you pass the exam and then practically you are with the patient, or you need a combination of everything. Yes, till the time you don't pass the exam, you will not be able to work as a consultant, but uh, you should have a balance. Okay, in MCQs there are true false, or there are choose the best. Okay, like that is called as BCQs or whatever. So this is usually unwritten, and there is in written there is SAQs, there is SEQs, and there is CRQs. And majority part of world, there is a combo. If you talk about UK, Ireland, some part even it was there in Pakistan, but now they have changed the pattern in Pakistan, and they have removed this SAQs or SEQs or a part, and only there are BCQs, which actually is a disaster. Unfortunately, I'm totally against it. Anyways, so now we come to what I am trusted to tell you when you target neuroanesthesia. Okay, so actually, the first thing is neurological. We should be knowing is neurological assessment. And sometime, because if you will open any neuro book, it will not written, so you will never do it. But this is the most important thing, that should be knowing how to assess a neurological system. That will be like something related to the conscious level. Okay, so conscious level will be, or and some things which will be related to conscious level will be maybe GCS or AVPU, okay, or higher mental functions, okay. So you can add on a lot of things, but basically the conscious level. Then that's the second thing you can say is the sensory system, then motor system, okay, and then autonomic nervous system. You know, you will be thinking that why it is important to understand this concept, because if you don't know this, the same thing will be immediately I will jump to neuromonitoring. Okay, if you will not understand neurological assessment, you cannot do neuromonitoring, because the same theory will be there when you will be listening the word neurophysiology monitoring. There is in this different part of world, it's done in different extent, but the basic concept is that if you don't understand how to assess the neurological system, the same theory will be there when they will be doing the neuromonitoring. This, in simple word, they so in neuromonitoring, there is a specific neurophysiologist who is doing it, and the part of it is actually some of them we are using isolated as a that one is BIS or entropy. This is one. Okay. They are doing 12 lead EEG, proper EEG. Okay. And their focus is to identify focal versus global ischemia. Okay. Because there will be a lot of other things, especially the vascular stuff. We will go in detail later on. But to just to make a concept, you should be thinking that whatever they are doing, the basic concept is to identify focal versus global ischemia. Okay, so this is one thing, and then they do the evoke potentials. Okay, and as anesthetists, you should be knowing that if they are doing evoke potentials, you will be, because this should be your first question: are you doing neurophysiology or not? If they are doing neurophysiology, you should be knowing what actually neurophysiology means, and whether they are doing it or not, and then you will be avoiding the medications which are affecting the evoke potentials. Okay, the evoke potentials are sensory evoke potentials, okay, in which they check the sensory system, the sensory pathways taking from the peripheral nerves to the sensory cortex. So you should be knowing what are different sensory pathways, whether it is like different sort of senses, including pain, okay, and they will be checking in the sensory cortex. This is one thing, and then there is motor, okay, these two things, and then there is auditory evoke potentials and visual evoke potential. The most sensitive one is auditory evoke potentials. So sometimes because we are not understanding the concept, so we are only thinking about sensory and motor, and we are missing auditory evoke potentials. So of course, the next step will be that different anesthetic agent we will be doing, inshallah, discuss later on. I have discussed a number of times before as well, but your approach will be that on the basis of this thing, you will be deciding which anesthetic agent you have to use and which not. So usually inhalational agents you will avoid, and you will use TIVA. Okay. So the next step in this concept will be that you should be learning about how to do TIVA, what are the pros and cons, what are the problems, challenges, how to do it. And then when we will correlate with practical conduct, even dedicated line with a driver fluid, a driver fluid, which is usually normal saline or ringer lactate or whatever. You have to make sure that it is going nicely. And it as a as a concept, usually it should be near to your foot side, because the patient will be draped and the surgical staff will be there covering that area. So usually you can use it in any line, but usually it's better to keep it towards you, because at the end of the surgery you will be removing it earlier than others, okay, other things. Or at any time you can disconnect it, so it will be easier to manage if it is nearer to you, okay. So this is the basic concept about it. Another topic which you should be knowing about is target control infusion, okay. So you see how I am correlating the things, and you will not find these things written in one book. You can only understand the concept, and then when you are reading it from articles or any book, you should be knowing that you have to bring out the answers to these questions. How you will, because practically if you are doing a neuro case, if you are working in a good setup, these things you should be knowing. If you don't know these things, you will lack. So I'm giving you the concept which will help you even in your practical conduct and even in the exams. So this is the basic concept you should be understanding about it. So I have correlated these things. And then sensory system, there will be some things to assess the sensory system, the motor system with the power, the different reflexes you will be doing. Okay. And for anesthetist, autonomic system is also very, very important, because autonomic system is the one which is like giving you the hemodynamic, okay, hemodynamics. Like if you have any patient which has autonomic dysfunction, like maybe it is diabetes, whether it is the any patient with the head injury, or any patient with the myasthenia gravis or tetanus, you can make a list out of it, that what are the patients who are having autonomic dysfunction. I'm sorry, any patient who has autonomic dysfunction, you should be having like the consequence of this autonomic dysfunction, you can say that you need arterial line in most of instances, because you need a meticulous look on the hemodynamic changes, number one. And you will be using judicious doses of anesthetic agents rather than blindly giving policies, because this can cause serious consequences. So if any patient with autonomic dysfunction, even positioning is dangerous. Sometimes, even if you are changing the position, and there can be sudden change in the hemodynamics. So that's why this is important. You will be assessing the conscious level, that what is the initial conscious level, because that will decide the postoperative course. If you have a patient with low GCS, most probably this patient can remain intubated and can go to ICU. So this will be the part of your assessment and part of your decision making and part of arrangement logistics, that this patient will be not be extubated. Most probably, I'm not saying that this is the only reason. Maybe you have a patient with 15 by 15 GCS, but still you need to shift the patient to ICU for a post-operative ventilation or monitoring. But this will be one point which will make you prepare for it. Okay, so there, because there will be logistics issues. You in some part of the world, anesthesia and ICU is the same department, but majority part of the world now it's separate. Okay, like in Saudi Arabia or US, or it's a, you can say 50-50 call now. But even then in the exam, you have to tell as a separate that we will be arranging post-operative ICU. Okay, so this will be one consideration, because if you have to extubate, your anesthetic agent will be a little different. You can give as much analgesia, you can give a liberal use of medications if you are not afraid that you will need to extubate the patient immediately. And you will be more cautious, because at the end of the surgery, if they are planning to have the neurological assessment, then maybe you need not to give medications that at the end of the surgery you are not able to extubate, because the patient is taking too much time to recover from anesthesia. So that will be the consideration. One will be the pathological condition for which the surgery is going on, the initial status, the post-operative length of surgery is not 100% criteria, But yes, it can cause, like if you have a surgery in prone position, or like patient has too much bleeding or anything. Keeping it at open, but you should be thinking that if you have to keep the patient ventilated, I'm repeating the same word, that you have to understand that this will be making your decision making important. So I hope you understand that this is the first step. Unfortunately, if you will bypass and you go directly to the next step, you will have problem. Okay, now I will correlate the next step, that usually the majority, there are a lot of things, but usually either it is trauma, okay, either it is tumor, okay, either it is, like you can say, some congenital anomalies, okay, or there is spontaneous bleeding. Okay, I'm using this. Usually, these will be the causes. Yes, at times, epilepsy is one of the cause for neurosurgeries. Okay, but usually it is either it is trauma, pure isolated neurotrauma, or polytrauma. So if it is polytrauma, you will have a lot of considerations. So this is one thing. Tumor is very important, because brain tumors, majority of times, they will be either in the form of like posterior fossa surgery, or it is like any craniotomy, okay, or one special is in the pituitary, that is transephinidal, okay. So in transephinidal, they are approaching from the nasal cavity. So, like, this is a little bit different, but you should, when they are telling you, another difference is, which is there not only in tumors, in some epilepsy surgery, is awake craniotomy. So this is another thing you should be thinking, because these things will be making your approach. Usually you should be knowing what you are doing. Okay, so posterior fossa surgery. So in all, there will be a lot of things which are common. We will be discussing in our subsequent session. I hope and I wish to continue it. I'm not sure how frequently I will be able to do it, but now we will have something. Okay, but my approach is not to make you feed you, making you notes and making you like a feel like a dependent baby. I am giving you a vision. If you understand this thing, believe me, knowledge will be nothing. It's very easy. Okay. So with reference to preoperative assessment or preoperative specifically neurological assessment, what is important, even if you have a surgery with for tumor, you should be assessing the preoperative neurological assessment. And the most important thing will be that any damage to either sensory system, motor system, autonomic system, and very important is preoperative any fits. Okay, because if the patient is having some fits, that anesthetic medications can have some effect on either side, and fits can be precipitated during the anesthesia, and it can create a challenging situation for you. Plus other thing, you, because that's why I say this word, I love anesthesia every day, more than yesterday, because every day you have new challenges. So and another thing why this is important, because if the patient is taking any anti-epileptic medications, now what will be the consideration with reference to epileptic medications is consideration is that the drug levels should have the therapeutic levels, because if the therapeutic levels are not achieved, this will create a problem. This is one thing, whether it is controlled and with the last fit. Okay, controlled or not, and when was the last fit. This is very important. Okay, and then another important thing will be the systemic effect of medications. So you should be knowing all the systemic effect of the medication the patient will be taking. Okay, so this will make if you heard the word fits, the next question which should be in your mind will be the one which I am just telling you. Okay, that what is the drug levels and everything which I have told you. So that's how you make a plan. That's how you make up your mind. It looks very simple, but there should be neurological documentation. Okay, that whether there is deficit or yes or no or whatever, because You have to compare it with postoperative, not only from your side, from the surgical side. Okay. If some, for example, there is some problem in the eyes before, okay, and now the surgery was done in prone position, and they claim that you did not make the positioning proper. Okay, so if you don't have any pre-operative documentation of the ophthalmic problem, what will you do? You cannot claim that it was pre-operatively till the time it was not documented. So it should be documented. So neurological status should be documented either by neurosurgeon or by the neurologist according to the different situations. But this thing should be in your mind, whether it's an acute emergency surgery or an elective procedure, as in tumor. Okay, by the way, tumor is never an elective procedure. You cannot delay it forever. Like, you cannot send the patient needs echo, and the tumor is growing and you are waiting for the echo. No, you have to, for any, this is common for any surgery, that always have a discussion with the surgeon. How much time you have, how much time I have, or how much time we have, how much time we have. This should be the question for every surgery. Make it your habit. How much time we have, sir? How much time we can get? How much optimization we can get? Okay, because time you are getting not to just document, but find out anything which you can optimize. And this point is there for any surgery. Believe me, if you are having any surgery on any patient condition, always discuss with the surgeon. I have a lot of discussions on how to study, how to plan anesthesia, and I have discussed these things with reference to every system, in the same way which I am trying to tell you today, with reference to neuroanesthesia. Okay, so that should be your approach. So tumor trauma, because that slide, I don't know where it went. Yes, just a second. Okay, so trauma. So trauma, in trauma, of course, trauma will be either as an open injury or something. But your basic approach, whether it is trauma or whether it is tumor, not only to document, and because primary injury will be there already, so you cannot do anything to the primary injury. Your approach is to target the avoidance of secondary injury. Okay, so whatever injury or whatever damage has been done, you will be looking at the next step. And next step is the same word will be for any, like primary injuries and primary impact, or I'm using the word openly because I'm trying to use it for tumor as well, because actually in the tumor it's almost the same. It's almost the same. Approach is the same. Yes, the word is different: primary brain injury and secondary brain injury. But secondary brain injury, whether it is through tumor or trauma, actually a number of things are the same. If you delay the tumor surgery, it will cause more secondary brain injury, and if any chances of recovery will go. Similarly, if you have a primary brain injury and now you are not avoiding, and by the way, the factors are the same, my best friend, my oxygen, CO2, temperature, sympathetic stress, okay, pain, okay, viscosity of the blood, mean arterial pressure, and more important, more specifically, cerebral perfusion pressure. Whether it is anything, the things which will be impacting the secondary impact is the same. Okay, so either there will be signs of high ICP with the Cushing's triad, okay, or in the surgery, what will be surgeon saying? Doctor, the brain is tight brain. Okay. Or you will have Cushing's triad. I have recently seen, it's my luck, I have not seen much of brain herniation. But recently I had a case in which there was actually a brain herniation. Okay. So brain herniation because of high ICP, and that patient has actually, that was a sickle cell disease, and that patient has ischemic injury, and then there was a sort of cortical vein thrombosis, and there was raised ICP, and the herniation was occurring inside. So they opened the brain immediately to do a decompressive craniotomy. Decompressive craniotomy. Decompressive craniotomy, by the way, it can be for extra dural hematoma, okay, or subdural hematoma. So actually, you should be like with reference to trauma, it will be for the form of hemorrhage, whether it is extradural hematoma, subdural hematoma, okay, or subarachnoid hemorrhage or intracerebral bleed. So your approach will be the same. So you see now things, I hope I'm just making sense of what I was trying to tell you, that first of all, whenever you have any case, primary assessment and planning. Primary assessment, documentation of the status, discussion with the surgeon, because neuroanesthesia, immediate emergent neurological interventions are can save the life. Yes, we will go in the next step that actually in some time there is surgery versus neurovascular interventional uh, interventions. Okay. So in which the patient is not having open surgery, the patient is through interventional radiologist, okay, but neurointerventional radiologist. But things should be clear in your mind what's happening. A lot of procedures they are for doing for subarachnoid hemorrhage. They're like aneurysms. They are doing it as a neurointerventional procedure plus stroke. Okay, in stroke, it's just like MI, like MI. There is a golden period in which immediately there is a stroke and they take the patient to the neurointerventional suite. Some of the people will not be familiar to it because it's not, the facility is not there in every part of world. In every hospital, it's not there. But of course, this is the future. Even with the stroke, there was a surgeon, very hard working surgeon. He was found unconscious on the bed way back in some part of world in where I was working, and he was immediately taken to the neurointerventional suite. They removed the clot. Can you believe? After I think 6 weeks, he was doing a surgery, and I was just saying salute to him, his courage, as well as the medical facility he got. So this is how it goes now. So you should be knowing, because you should be knowing, even if there are like because I am a sensitive person, I try to attend all the concerns. A lot of people will be saying, oh sir, this is not in our part of world. So why you are not preparing yourself and pray that you one day you will be working in such setup. So what will you do? You will try to learn at that day. Eyes cannot see what mind does not know. If you don't know even at all, what will you do in the exam? You will say, because in our hospital it's not available, so it's not allowed for me to study. I cannot have a knowledge of the thing which I don't see. No, there is no explanation. You have to know. Even it's not there. You cannot have self-pity. Come out of self-pity, my dear. Even if you are working in any part of world, if you even if you don't know, no problem. Hope for the best. At any day, your fate can change. And what will you say that day? You will learn at that day? No. You have to know everything. So, and it's very easy. It's not difficult. Believe me, it's not difficult. If you have the vision, uh, you can do it. Okay. Yes, of course, the things which you don't practice, you forget. But that's what a learning period is. If you in the learning training period, if you don't know, then you will be becoming a old duck like me or any senior person. Then it's difficult for you to learn. But during your training, you should be knowing everything. Another thing which is actually also related to the intraoperative thing, but I'm just telling you because I'm telling you about neurophysiology. So I'm also using another thing which actually I don't have very good concept about it, but it's navigation. Okay. Navigation, actually, it's what I understood. I try to understand, but unfortunately I'm lazy at that time. We are more concerned by in stabilizing the patient, making the position and everything. But actually, this is very important thing that with navigation, the word navigation is telling you they are trying to find the angle, distance, and easy approachability, avoiding the neurological issue as much as possible, in which they have some special system by which they make a track, angle, distances. They record it so that when they are doing the surgery, it is helping them. Okay, to avoid not only reducing the time, Yes, reducing the time to during the surgery, but in the start, sometime the patient is anesthetized at 7:30 or 8 o'clock, and the surgery is starting. I have seen even 12:30 in King Faisal when I used to do it. They used to start the surgery. Another thing. Sometimes there are operation theaters in which there is a MRI suit. It's my luck that I have seen these things, but I'm just telling you, as I mentioned, that you should be, because I had no idea what is happening. So I want you to know at least that there is a concept of anesthetizing the patient, doing an MRI and doing the surgery, and then repeat an MRI before kicking the patient out of the operation theater. They just repeat that. If I have not seen that they repeat, open the brain again, but usually they just document it. They see whether they have removed everything or not. I have not seen them reopening, but theoretically they say that maybe we need to reopen. They do the repeat MRI with the hope that maybe they need to repeat it. Anyways, so there are MRI suits. So sometimes it takes so many hours to prepare the patient for everything. So up till now, like I'm giving you a sense, how will you proceed? Can any volunteer tell me up till now anything which I have missed in the preparation of the patient for neuroanesthesia? Yes, there will be a lot of things in different system, because if you have vascular things, because carotid endarterectomy is also neuroanesthesia. Okay, carotid endarterectomy is also neuroanesthesia. You should be knowing about it. Uh, the epileptic the awake craniotomy for epilepsy is also neuroanesthesia. Tumor trauma, with reference to, I am very bad in it, but you should be knowing the CT scan and MRI visualization. I'm unfortunately I couldn't learn up till now. I feel myself blind when I look at a CT scan or MRI. I'm very bad in it. But the people who are working in ICU, because unfortunately in Saudi Arabia, I'm out of ICU for last 10 years. I have never worked in ICU unless in on except for in COVID time. So that's I will suggest you to know how to identify extradural or subdural, or how to see the midline shift or things like that. Okay, at least basic CT scan, because even they come in the OSCE exam, they come in the oral exam also, they can ask you. So you should be knowing about the thing. Then vascular, as I told you, then we will just try to see some other things also, like carotid Doppler is one of the thing which you should be knowing, and then carotid CT angio. CT angio. Okay, then I was, because I did not have this knowledge, so that's why I use this word, the mention, which is there in my logo as well. The day of the life, when you wake up in the morning and sleep without learning something new, which you don't know before, and without teaching something you know and the other person doesn't know, that day of life you waste. So one day I had no idea. I was discussing with him, with the neuro, that the patient does not have the carotid Doppler, and that day I came to know that CT angio is more of a gold standard for assessing the vascularity as compared to Doppler. But again, that day I understand this is an static, really static measurement, and this is a dynamic. Okay, because in which they are seeing the carotid flow as a dynamic. Okay, so maybe this is my theory, this is my understanding, that a combination will be giving much better result than only one thing. But another thing, that carotid Doppler finding is also operator based. Okay, because operator angles will change the result. So this is also important thing, that the way operator is doing the assessment can change the result. But CT angio is a different thing. Okay. But both of them, the purpose is the same, to see the vascularity going to the brain. And then with the physiological step, you should be knowing the brain, the very famous circle of Willis. So the people who are studying for any exam, they should be knowing how to draw it, what are the vessels from the anterior side. I don't remember anything, but you should be knowing the circle of Willis. Because any finding in CT angio or carotid Doppler, you should be, next step should be, just like you should be knowing the coronary blood flow. If you don't know how to have what are the different vessels which are supplying the brain, how will you evaluate? Okay, so this is how you will be doing. Then we will just try to sum up the things. The basic investigations will be the same, but there is no concept of baseline. Basic investigation and baseline investigations are different. Remember one thing, if you say I will do routine investigation, there is nothing like routine investigation. You should be knowing why you are doing any investigation. Yes, CBC to see the hemoglobin, to see the platelet count, to see any the WBC count, things like that. You can explain anything. Then the renal function, the electrolyte, okay, the liver functions, especially if the patient is taking any anti-epileptics. Okay, because otherwise you cannot correlate why you are doing these tests. Okay, then the CT scan, MRI, as we discussed. Then what other investigations? CT, MRI, this vascular investigation. Can someone help me? Anyone wants to add on, because we have 5 more minutes and we will continue our discussion. Anyone wants to speak out? Anything, please? Anything anyone want to add on till in what I have told you up till now? Ikra, Sajid, anyone wants to add on? Well, actually, I was not prepared. I just thought to have something. Anyways, if I forget, because tomorrow I will just try to re-evaluate what I have told you. Okay, so actually this will be a number of people ask from where to study. So I will tell you few things. This is the folder which I have made, and unfortunately none of you look at it. I sent this folder so many times, and you people don't have time to have a look clearly, openly. You will find so many things. Okay, and remember one thing, that this is just like a bank. Okay, no lady will mind having her cupboard full of all the dresses, and rather she will be worried what to wear. So similarly, this some article will be helping you in some topic, in some aspect, and you can have same topic with different like years. Maybe some things will be new. Okay, so that is how you will be using it as a library, and you will find so many things. Okay, you will find so many things. Unfortunately, I'm not able to arrange in, as I will try to arrange some of them, because I thought to have detailed discussion of every system. I'm not sure how many months, sorry, how many days or weeks I will take, but I will try to discuss everything about neuroanesthesia in the way which I have told you. So you can open all the folders and you will find different variety of things. But the thing the point is the same. You should be knowing what you are doing. And if you are just thinking that you will find a note with points, you will cram it and pass the exam, I'm sorry, it's not like that. If you want to become a doctor like this is an insult to the medical science. This is serious business. You will be dealing with someone's mother, father, brother, sister. Would you like to be anesthetized by someone who became anesthetist like that? Or would you like some of your dearest family member to be anesthetized by someone like that? No, you should be knowing, if you are using mannitol, how to use it. How much is the dose? What's the mechanism of action? What will be the immediate problems you can have when you are using mannitol, say, okay? And then if that when the surgeon is saying you the brain is tight, what you should do immediately, what you should be looking at, you will be looking at the possible reversible things, but immediately your response will be, you will make the patient a little bit hyperventilate. Okay, you will try to see, maybe you can do an ABGs to see what's the status at that time. Okay, then what else you will be doing? The next step will be going to the pharmacological therapies, the mannitol or furosemide, or the next step will be the surgical. If still the patient is not able to treat it, then they will go for any drain, even ventricular drain, or from the in some cases when they are if they are a number of time, they put a lumbar drain to start with. I have seen, this is another thing which I forgot to tell you, that a number of surgeries in which they are expecting this thing, they actually put a lumbar drain before they start. So this is another step which they take, that after doing everything, You are making the patient lateral, they put a lumbar drain, fix it, and then you make the final position, whether it is beach chair position or it is posterior prone position or anyone. Okay. Then another important, I'm just trying to tell you, this is just like a trailer, and we will try to cover each and everything. Like patient is, they are doing the pinning, they are putting the Durapin, the Mayfair pin. I am, if I'm not wrong, it's a Mayfair or whatever. When they put the patient head hanging, and they put a pin. So there are different strategies to handle it. There is a scalp block, which should be knowing about it, or you will increase the depth of anesthesia from 1 Mach to around 3 Mach, so that this stress response is gone. You will try to give paracetamol or NSAID, or a big dose of propofol, or increase the, because there are different strategies you can use. So we will just trying to have the pros and cons of different strategies. So this is in an important step: tight brain positioning, neurophysiology, neuromonitoring, base level, then TIVA, TCI. This, you see, this is a world of topics. And believe me, if you work hard for some time, this knowledge will not remain to only neuroanesthesia. A number of things will be, if different. Whenever the word hypotensive anesthesia will come, TIVA and TCI will come. Any patient having nerve monitoring, any patient having nerve monitoring, you can use this technique, because in nerve monitoring they are not, the difference is only, then in nerve monitoring, like facial nerve monitoring, they are doing parotid surgery, and they tell you, we are monitoring facial nerve, don't give muscle relaxant. Okay, similarly they are doing this middle ear surgery, we will be doing, so you can give an initial dose. Some people will say, don't give muscle relaxant. I don't because by the time they make the position and reach to the nerve, actually the muscle relaxant effect is finished. But usually I prefer to use rocuronium, because rocuronium you can reverse with the Sugamedex. Number one. Number two, it's a predictable effect. And another technique, which you will be, remember one thing: if you are using muscle relaxant with inhalational agent, I repeat, if you are using muscle relaxant with inhalational agent, if you want if you are giving good amount of muscle relaxant, the requirement of inhalational agent will be slightly reduced. Similarly, if you are using and you want to reverse, don't use too much inhalational agent, try to use some alternative, so that the, because inhalational agents have dose dependent effect on the neuromuscular function. Okay, all of the inhalational agents. So if you have this thing in your mind, don't put the dial on too high. Okay, you can use, at that time you can use some propofol, you can use some midazolam, you can use some presidex, you can give a little bit if there, it's like in my book there is no contraindication to very very small tiny puny dose of ketamine, but you can use it. Okay, so like there will be so many options to do it. Try to reduce the use of inhalational agent versus muscle relaxant, because they will increase or decrease the requirement of each other. Okay, so this is one point. So similarly, I will finish here because I have to go to pray, and I hope it gave you some sense. Okay. And now whenever you can use this folder, the other thing which you might need to add on, because unfortunately I'm not able to arrange, because there are two folders, one is art topic wise and one is year wise. Okay, so if you want to see that any new article came on neuroanesthesia, just you have to come here, and you will see, yes, minovalingocele is here. Okay, then you will see here, uh, what else has come. You will find, actually I saw craniopharyngioma was also there somewhere. So like, you will enter here, I have arranged year wise. Please at least spend that much minutes which I have used or spend my time for you. I'm not appearing in an exam, I'm not an examiner, I'm not a supervisor, I'm doing it all for you. And it really disappoints me when you are not able to open it even. This is for you. Some of them are free, some of them are paid actually. Okay, this is BGA education. I'm using one of my friends access, thanks to him. I will not tell his name, because maybe, anyways. So this is BGA education up to right now August. all articles are there. Maybe you will find some neuro. So you just have to, how many minutes you will have. You just have a look where are the things, and then you will be able to track it, because it needs energy. Okay, I don't know where it has gone. Okay, so this is also, because actually before it was separate link. I tried to transfer all of them. I think some of them are missing. Anyways, the message which you receive, actually in that message all the links are there. This one, year wise, topic wise, all links are there. So I just saw some of them are missing. So if it is not here, it will be there in the separate year wise, because before, you see, I'm just telling you, I bought this extra storage because it was moving above 15 GB. So above 15 GB you have to buy it. I'm not asking anything from you. I'm only asking that you should use it, because if you will use it, I will feel satisfied that at least if I spend something for you people, you use it. If you don't use it, it's a disappointment. Similarly, this is a very good source. Okay. So unfortunately, the subscription for this is finished. I will re buy it. It needs some money. Okay. But here you will find all of them are arranged year wise. Okay. So you will open it and you will find, you see, this is a message for me as well. I think when I transfer, not everything is transferred. So I need to recheck about it. But there is a separate link for it for year wise. I will show you because it was in a separate link. Okay, let me show you. Yes. So just a second, please. Few minutes, we will be finishing. Any questions, please? Anyone wants to have anything? Yeah, so this was the original link. I transfer from my side, but I think I need to recheck. You see, it's very difficult to manage all these things separately. Okay, so this is, I hope here it's there. Okay, so because the subscription was finished, and here you will find. Okay, so here you go. So all the folders are here. I will I will try to transfer all of them there. So, so here these three, and then another important thing is updates in anesthesia. Okay, so every year there is an update. So you will find here all the updates. The latest one was for pediatric anesthesia. This was in 2023. Okay, so it's a wonderful source. And remember one thing, you don't need to cram each and every word of each and every line of every source. You just have to compare. You will find it and then you have to compare it with others. So that's what I wanted to tell you. I hope that give you some idea about how to study. And we will continue our discussion from here on. Thanks a lot for your time, and feel free to contact me any time you want. Thank you. No one wants to ask any question, any comments, nothing, no words. Anyone alive or all anesthetized? Okay, bye bye. I'm just a message away. Anyone can contact me anytime. So I can see some people from different part of world. I think some are from Egypt. So thanks a lot. Special thanks to all of you. Bye bye. See you.
Allah Hafiz, Dr. Zishan.
Thank you. Salam.